Good morning, Michael. I'm here in London on a personal visit. I've never seen a summer of 31 Celsius.
Hi, Raju. So you are very lucky, and because weather in England can be very unpredictable. But let's go back to medicine. I was just contacted by my colleague ophthalmologist who informed me that one of our JIA patients, currently under adalimumab for anterior uveitis, had a new flare uh, observed during a routine follow-up. So we are lucky in Lausanne that we collaborate with an excellent team in the eye clinic since 25 years. And thanks to the JIA cohort that we use as a medical record for communication between us, then it's very easy to collaborate. And also the ophthalmologists are taking care of ocular inflammation and topical treatment, and we take care of the systemic treatment. And additionally, we have once a year a common consultation with our colleague ophthalmologist. But on your side, Raju, do you see many patients with JIA associated uveitis?
So, Michael, we too are very fortunate to have a good multidisciplinary team. And actually, just yesterday, we were in a meeting with the Uveitis Society of India, where there were some fascinating cases that were presented. But looking at our own series, we are very, very strict and we follow up our young ANA positive girls with oligoarticular JIA very meticulously. So, while actually irregular screening has been cited as a reason for possibly uh, reduced prevalence of uveitis in our side of the world, I truly think that in our geography, uveitis is less frequently seen. But coming back to your patient with the flare, who you mentioned was under biological therapy, uh, had she failed methotrexate?
So we did not try methotrexate in this young lady since she was intolerant to the drug when she was treated for her arthritis. And furthermore, most of our patients with JIA uveitis are not responding to methotrexate. So we are directly treating with adalimumab to avoid side-threatening complications.
And what are the complications you see in these JIA uveitis patients?
So the first line treatment for anterior uveitis are topical steroids, and if used for many months, they might induce glaucoma and cataract. And sustained ocular inflammation is also susceptible to cause ocular damage, as shown by older studies. So, in consequence, it's important to control uveitis rapidly. And we also see that in our consultation that more rapid and aggressive treatment decrease the occurrence of complications.
I have actually read that cystoid macular edema is the commonest cause of visual loss. But tell me, Michael, besides adalimumab, do you use other TNF blockers like etanercept, for example?
No, the TNF receptor fusion protein etanercept has not proven its efficacy in controlling uveitis over placebo. And also, we see that uveitis can develop in GIA patients under this treatment. You can use other antibodies against the TNF like infliximab or golimumab for uveitis treatment. In our patient, GIA uveitis was controlled under adalimumab since 3 years. And so we could increase the interval between the injection. But now, because of the flare, we will go back to biweekly injections.
It's well recognized and known that uveitis control may slip on the same therapy after varying periods of time. And why do you think this could be probably happening?
So It's recommended to use methotrexate in combination with adalimumab to treat uveitis. The problem is that we see many patients who are intolerant to methotrexate. That's the reason why we usually use adalimumab as a monotherapy. And so the risk when you don't use methotrexate is the development of anti-adalimumab antibodies that may block the efficacy of the drug. And methotrexate is supposed to reduce this antibody response and can also reverse this antibody response if you treat newly a patient with methotrexate. But our patient was intolerant to methotrexate.
But while you are speaking about anti-adalimumab antibodies, do you check for these regularly in your patient?
So we check these antibodies once a year, or if we see that under treatment, we get some resistance, so a new onset inflammation. But there is nothing in the literature to really tell when and how we should monitor these antibodies. For our case, I was thinking also about the alternative in case our treatment, adalimumab, will fail to control again inflammation. And I came across a review paper about the use of tocilizumab in JIA uveitis. But what is your experience with this drug, Raju?
No, that was an interesting thought, Michael, to think one step ahead. But truly, I have not used tocilizumab to date for uveitis. But what we do is, because we have constraints with cost, when we find that methotrexate is not doing its job, we add mycophenolate to methotrexate. And we also have to keep in mind that adalimumab is our third line, but with tuberculosis in our country, we are always concerned about a flare up, and obviously, the cost is a concern. But coming back to your mention about tocilizumab, what did you learn about tocilizumab from this review?
So tocilizumab is an anti-IL-6 receptor antibody. So it was chosen for the dose selection because the individual levels of IL-6 show a great variability, which is not the case for IL-6 receptor. And we know tocilizumab since many years because we use this drug in polyarticular JIA and systemic JIA. And we had a very good experience with this drug. But now coming back to uveitis and JIA uveitis, this review paper has a nice table with the different studies over the last 10 years that have shown the efficacy of tocilizumab in uveitis, in particular on macular edema. I would like to mention two of them. The first one is from Tapainer in 2016, who showed in a retrospective study on 17 patients with refractory uveitis that tocilizumab could induce inactivity of the uveitis in 10 patients within 6 months. And in another multicenter study, tocilizumab was efficacious to improve ocular inflammation in almost 80% of 25 patients, and again within 6 months of treatment. But there is an additional point that is interesting with tocilizumab is that it's possible to give it subcutaneously or IV in infusions. So it gives you a little bit more flexibility for the patient.
And I'm sure one of these studies must have shown that IL 6 levels in the anterior chamber are elevated to support their study. But do you see other alternatives to adalimumab and tocilizumab in the horizon?
So when you look for another molecule, abatacept, from studies with a small number of patients, it seems efficacious, but less than tocilizumab. And also, we need more studies, in particular, to evaluate if abatacept gives a sustained response against ocular inflammation. And there is another group of drugs that we can give orally that are the JAK inhibitors. And here, both baricitinib and tofacitinib are on ongoing RCTs for refractory uveitis. But there are some case series that have already shown efficacy of these drugs on uveitis, but not as much as for arthritis.
Michael, I feel very relieved to note that for a disease that can have irreversible threats to the little eyes that we look after, there is an expanding armamentarium of drugs.
I agree, Raju. This is very important because our patient need to have a vision for maybe 70, 80, or 90 years. So we really need to be very careful to control ocular inflammation. So as usual, it was a nice discussion. Goodbye, Raju.
Goodbye.